Assessing the Newborn, Chapter 21. Newborns are a specialized population to be assessed. Assessing a newborn is somewhat similar to assessing an adult patient, an adolescent patient, but there are certain assessments that have to be also conducted with the newborn. The newborn is the term used for a child from birth through 28 days old, so about a month. The newborn makes multiple adjustments to its respiratory as well as its circulatory system as it adjusts to extrauterine life. I am also posting for you Fetal Circulation Made Easy to help you identify fetal circulation and then the adaptations that occur in fetal circulation, the adaptations that occur after the baby takes its first breath outside of the uterus. So going from head to toe, the head is the probably the largest in diameter portion of the neonate's body. The skull of a newborn is very soft, it's very flexible, and there are fontanelles, which we also call soft spots. There's one anteriorly that is the shape of a diamond, and then there's one posteriorly right between the parietal bones and the occipital bone, and that's in the shape of a triangle. And those are two soft spots. The bones are also separated by sutures. And the separation and the fontanelles allow for further brain development. The average head circumference is about 34 centimeters, and the average head is usually about 2 centimeters larger than the chest circumference. The skin is critical to the newborn's child's transition from intrauterine environment to the extrauterine environment. The skin isn't fully developed at birth and usually matures with age. It's usually very smooth, very thin. You can definitely see vessels underneath the skin. They don't have a lot of subcutaneous tissue, so therefore the lack of subcutaneous makes it so babies get cold more easily. Mottling is commonly seen, usually in the trunks and extremities. And at birth, there's a thick, cheesy, waxy substance called vernix that helps cover the skin, and it's a protective layer to help warm up the baby and keep the baby's skin lubricated. Hair is called lanugo. You have lanugo all over the body, and it's usually soft, fine hair that covers most of the newborn, and it keeps that baby warm. It's kind of like peach fuzz. Babies are also obligate nose breathers, so they tend to breathe with their nose, especially when they're breastfeeding. They breathe in and out through their nose and not necessarily through their mouth. And their neck is short, and their neck muscles are very weak. So it's important when you're holding a newborn that you're supporting the head. And remember, the head is the heaviest, largest part of the infant body. The eyes, macula is absent at birth. Infants really don't have central vision. Their vision is really blurry and can see up to about 6 inches. Peripheral vision is developed at birth, but again, their vision is very fuzzy after 6 inches out. Their ears are very soft. The cartilage isn't fully developed. The eustachian tubes are shorter, they're wider, and they're a little bit more horizontal to the ear canal. And newborns tend to respond better to higher pitched sounds and noises. The abdomen is usually full, it's more rounded. At birth, the umbilical stump is usually present. The umbilical cord has 2 arteries and 1 vein, and of course the arteries and vein are kind of opposite of what we're used to, where the arteries carry deoxygenated blood and veins carried oxygenated blood. The urinary system is located between the symphysis pubis and the umbilicus. And the neurological system, again, is not fully developed at birth, and there are some primitive reflexes that we'll be assessing to kind of determine how neurologically intact they are. And some of those reflexes are not yet intact. And one example is the Babinski. So, NCLEX question. You're assessing a newborn's skin. What is the true statement about the newborn's skin? If you said that the skin's very soft, is not fully developed at birth and matures with age, then you're correct. Skin will vary depending on the length of pregnancy. So, if a pregnancy is premature, the skin will be very, very fine, very smooth. There will be minimal to no subcutaneous tissue, where the further the more term rather they are, the thicker the skin. Their skin is still smooth, but a little bit more subcutaneous tissue is developed. So babies after they're born usually have diagnostic tests and usually are done in the nursery before discharge. And some of these include metabolic profiling, PKU testing, bilirubin testing, as well as glucose screening. When working in the nursery, it's important to include parents in the assessment process from the moment of the newborn's birth. The mom, the parents, the primary caretaker are really the primary sources for gathering information about the newborn, and cultural variations among families should also be taken into consideration. And we don't exclude old carts or cold spa or whatever mnemonic you like to use when identifying complications that are attributed to a symptom that's presented. So the start of collecting our health history occurs with reviewing the past as well as the perinatal history, and that's the mom's pregnancy history. With the mom, we want to determine her history of having hypertension, anemia, diabetes, which all are considered vascular comorbidities that can impact the placental uterine perfusion. We want to determine if there was any premature labor, any antepartum bleeding. We also want to determine what the baby's blood type is. Infants born to moms with any negative blood type or Rh negative factors. Sometimes the moms will end up having to get RhoGAM. O types are, as well as negative blood types, those babies are at increased risk for jaundice or increased, unconjugated bilirubin in their body. They're not able to eliminate that bilirubin, or which is kind of like a toxic chemical. They normally eliminate bilirubin through both the GI system as well as the urinary system. Any accumulation of bilirubin in the body can transfer to the brain, across the blood-brain barrier, and can result in kernicterus, which is neurologically impacting the infant. We also want to identify if there were any illnesses or infectious diseases during pregnancy. Going through the torch infections, viruses can easily cross the placenta and can have teratogenic effects on the fetus. We want to identify the mom's HIV as well as hepatitis status. We want to review whether or not they had group beta strep and whether or not they were treated during labor and delivery, and how many doses of antibiotics they received, and whether they have a history of gonorrhea or chlamydia. We want to identify types of medication that were taken during pregnancy, whether it was pregnancy-related medications or whether medications were taken for patients' comorbidities such as thyroid, hypertension, diabetes. Were there any other prescription herbal or over-the-counter medications that were taken? We want to also, with the mom, identify their mental health status, history of baby blues, which is a self-limiting psychological kind of, I don't want to say normal, but more of a path that some moms will take, and it's just kind of based on the fluctuation of their hormones after birth. And we want to determine whether it's baby blues or whether it's postpartum depression, which is not self-limiting, which very much mimics depression signs and symptoms, and with that we would administer to the mom the Edinburgh postnatal depression screening to determine if she's at risk for postpartum depression or has postpartum depression. We also want to identify something that's not listed here, psychosis, postpartum psychosis, which is postpartum depression associated with hallucinations, delusions, and fear of maybe harming self or child. We want to identify psychosocial history, smoking, drinking, drug use, as well as substance use and abuse. We want to go over the family history. Are there any history of birth defects, congenital, cardiac, or blood disorders? And then we want to talk about their birth history. Were they born on time? Were their membranes ruptured? How many hours? How long was their labor? How did they deliver? Was it by vaginal delivery, C-section? What were the APGARs at the time of birth, as well as were any resuscitation measures taken after birth? We want to ask about their APGAR, and remember APGAR is a quick assessment that's done at 1 minute and 5 minutes based on 5 criteria: heart rate, respiratory rate, muscle tone, which talks to us about the neurological system, and the reflex irritability, which also talks to us about their neurological system, as well as skin color, whether there was adequate oxygenation or lack thereof. So pulmonary, cardiac, neurological, and then just general overall assessment. You're taking a health history on a mom who has diabetes during her pregnancy. The newborn weighed about 9 pounds. What is the medical term used for an infant that is greater than 4,000 grams? If you said macrosomia, you're correct. The best place to assess a newborn is on a radiant bed warmer. The radiant warmer should be pre-warmed before the infant is placed on the surface to really avoid any type of heat loss, because babies will lose heat very easily and very quickly. In a warm environment, they should be undressed and placed under the warmer. And McEwen developed a mnemonic as a useful adjunct to conduct a newborn assessment. BEATS: background of the mom, background of the pregnancy, background of the labor and delivery, identifying external head to toe, determine how their airway looks, touch, as well as sound. And you can refer to table 21.1 in your book. It goes through this, and I will tell you what page it is on shortly. So it's on page 409. Gestational age assessment is also something else that you want to do. An easy assessment is to use the Ballard's assessment tool, and this kind of gives us an idea of both their neuromuscular as well as physical examination. And if we're unsure of what their gestational age is, we can use the Ballard scale to help us determine this. And again, it determines gestational age through both neuromuscular as well as physical assessment. Score is on a range of -1 to 4 or 5. Usually should be completed within 2 hours. And the tool is available on the module, so you can see an example of what that tool looks like, and you can also see an example of the tool on page 410. The Ballard's assesses for posture, square window, arm recoil, whether they're able to recoil their arms, their popliteal angle, scarf sign. heel to ear, as well as skin. And then the physical assesses lanugo, plantar surface, whether there's creases and how much. Their breast, identifying the areola and the size, eyes and ears and their location, as well as the development of both the male and the female genitalia. And based on this, you can kind of identify how many weeks they truly are. Normal findings for the assessment include AGA, or appropriate for gestational age, where the weight, if it's calculated, is between the 10th and the 90th percentile, and a full-term pregnancy is usually between 39 weeks and 40 weeks and 6/7 days. Anything after the 40 and 6/7, we call that post term. We also want to assess their weight to determine where they are on the spectrum of whether they're underweight or overweight. And again, we said in the previous slide, 10 to 90th percentile is usually where we want them to be. 50th is the, that sweet spot. When assessing their weight, again, we want to keep them nice and warm, and we can use the receiving blanket on the scale and calibrate the scale after we place the receiving blanket, and then place the infant gently on and record their weight both in grams as well as in pounds. And this is also important. If the infant needs medication, we need to be very vigilant about how much they weigh, and to determine, the approximate dosage based on their weight. And we can plot their weight on the curve, and that also is taken to their pediatrician's office to determine whether they are they're falling off the curve or whether they're staying on the curve. Normal weight is usually between 5 pounds 8 ounces to about 8 pounds 13 ounces, and an average is about 7 pounds 8 ounces. It's normal for infants to lose about 10% of body weight within the first 3 to 5 days. And remember, they were in a body of water in utero, so they had a lot of absorption of that fluid, and they tend to, after birth, release that fluid, whether through elimination. They don't perspire, but they do eliminate some of that weight. We also want to obtain their length. We use a paper tape in order to do this. By doing this, we're laying them down. We can use the warmer bed or the scale, and we're measuring from the heel up to the top of their head. When we're recording their length, we're measuring in inches as well as in centimeters, and we're plotting that on their growth curve. Normal length is usually between 45 to 55 centimeters, or 18 to 22 inches. And you also want to take a look at the parents. Sometimes infants can be on the 18 inches. Are the parents on the shorter side, or are they on the taller side? We'll also be measuring chest circumference at the nipple line. And a normal chest circumference is between 30 to 33 centimeters. And again, usually the chest circumference is smaller than the head circumference. We're measuring the head circumference by paper tape, and we would do it right at the level of the eyebrows. And a normal head circumference is usually between 33 to 35.5 centimeters. We're measuring their axillary temperature to determine body core temperature, and usually we would go routinely to do an axillary temperature. The more accurate temperature reading is the rectal. However, rectal is not routinely done because of the risks of perforation unless ordered by the pediatrician or neonatologist. Normal range temperature is between 97.7 and 99.3 degrees Fahrenheit. We would assess their heart rate, and usually fetal infant heart rates are very rapid. So once you've determined what their heart rate is, you should check the heart rate for 1 full minute, listening for any murmurs or changes in rhythm. Usually the smaller stethoscope is used. If you don't have one of their smaller stethoscopes or neonatal stethoscopes, you can always use the bell part of your stethoscope to auscultate and count again the apical heart rate for 1 full minute. You want to assess their respiratory rate, again, using the stethoscope. And what you can also do is place your hand on their abdomen and just feel for the full rise and fall. They will have episodes, some episodes of apnea, which are actually normal. And remember, infants are nasal breathers. So it's important to really monitor their respirations. And you want to count their respirations for a full minute. Normal respiratory rate is usually between 30 to 60 breaths per minute. You want to assess their blood pressure, and usually blood pressure is checked only one time. It's not routinely checked in the pediatrician's office. And the cuff should cover about 2/3 of the upper arm or the upper leg. And it's important that when you're assessing their blood pressure, that they're at a rested phase, preferably when they're asleep, preferably when their extremities aren't in motion, because you can get false readings. And normal neonate blood pressure is usually between 67 to 84 systolic to 35/53 diastolic. And it does vary for, their age. Question. You're preparing to weigh a newborn infant for the first time. The infant has not had a bath. Put in order the sequence of the assessment. If you said put gloves on first, put the receiving blanket on the scale, calibrate the scale, take off the diaper, and then gently place the infant on the scale, you're correct. General assessment, so very similar to assess the newborn system for any anomalies, abnormalities, any neurological issues. And it's important to try to keep the baby as warm as possible because they can become cold very quickly. So when you are conducting a newborn, head to toe assessment, you preferably would need to do it under a warmer so that they remain warm. You want to stand at their side and inspect, and try to conduct this assessment when they are at resting phase, or maybe when they're kind of half asleep, or when they've been breastfed very well. You want to assess their skin. Note for any changes in coloration. They should be pink throughout, although acrocyanosis is usually documented within the first 12 hours of life, and that's simply bluer hands and feet as the circulatory system is adjusting. Normal findings with the skin, again, depend on gestational age and ethnicity. Preterm infants usually will have lanugo and vernix. Postterm infants will have more peeling, more dry, more cracked skin. Normal findings include milia, which are the little white spots on the nose or the chin. Stork bites around the neck, little red marks, Mongolian spots, cafe au lait, as well as diaper rash, which is erythema toxicum. Abnormal findings include jaundice before the 24-hour time frame, paler mottled skin that is throughout the body, or central cyanosis, or petechiae. And petechiae can be resulting from injury from birth, or it could be a blood disorder or trauma. So you want to start off with a head to toe, inspect any abnormalities of the head, assess the anterior and posterior fontanelles, and assess the suture linings, and making sure that there is a slight separation between the sutures. Again, palpating the fontanelles and palpating the sutures. The head should be symmetrical, normal, the fontanelle should be flat, and the sutures should be separated. Any evidence of bulging fontanelles could indicate trauma within the cranium, bleeding, or fluid. Any depressed fontanelles could indicate dehydration. We want to assess the face and look for symmetry. Compare side to side. We want to look at the eyes, look at the color of their eyes, the conjunctiva, any edema. Usually edema could be related to prolonged pushing. We want to assess their nose for patency. Look for any flaring of the nostrils that can indicate respiratory distress. We want to assess the ears for size and position. Usually if they are lower than the outer canthus, that could indicate a genetic or a chromosomal anomaly. And we want to also conduct a hearing screen. One quick hearing screen is to clap near their ear, and sometimes they'll startle or they'll turn to the direction of that sound. We want to assess their mouth. Use a gloved finger, palpate the palate, make sure that they're intact. And with the mouth, we also want to assess sucking, gagging, as well as the rooting reflex, which is assessing their neurological system. Normal findings include symmetry throughout, patency of the nose, normally placed ears, normal pink and moist mucous membranes of the mouth, and there is motion of the head from side to side, symmetric movements, as well as rooting, sucking, and gag reflexes, which indicate normal neurological system. And these are abnormal findings, which are pretty much opposite of what we talked about. You can also assess the neck and range of motion of the neck to determine motion and movement. There should be full range of motion, and again, we talked that the neck is a little shorter, thick. There shouldn't be any evidence of webbing that can indicate a chromosomal anomaly, such as Down syndrome. The newborn was delivered vaginally without complication, and you're palpating the head for the first time. You palpate overriding sutures. What should you do next? If you said D, you're correct. Sometimes overriding sutures can just be related to molding from the vaginal delivery. But you should continue to palpate to make sure that there are no closures of the fontanelles, because that can indicate a neurological problem as well as a cranial problem. You want to assess capillary refill and perfusion by placing your finger pads of your index finger right on the sternum and looking for any blanching and noting the time. And there should be a return within less than 3 seconds. We're also assessing peripheral perfusion. So the previous was central perfusion. We're now looking at peripheral perfusion. Again, we're placing our index finger on their hands and palpating the right and left brachial pulses, and assessing, perfusion on and identifying rate, rhythm, as well as symmetrical pulsation. And this is just an elaboration of how that's done. And normal findings would be that they're present, that they're equal rate as well as rhythm. We want to assess the respiratory system by using our stethoscope. And we're looking for, again, the rise and fall of their breathing. One full cycle is one rise and fall. And we can use the bell of our stethoscope to auscultate both the anterior as well as the posterior lungs, looking for clear, equal bilateral breath sounds from the base to the apex. And when we're assessing breath sounds, we move them from side to side. We don't have to sit them up. When inspecting their chest, there should be no retractions. They should have a respiratory rate between 30 and 60. When they're in the resting phase, it's usually closer to the 30. When they're in a more active phase, that's usually closer to the 60. And breath sounds should be clear bilaterally. We are inspecting and palpating the chest wall, looking for symmetry. We're looking to determine the number of nipples, making sure that there's an imaginary line between each nipple and that it matches. The chest should be symmetrical, clavicle should be intact. That would indicate no trauma from birth. And there should be about 6 millimeters in diameter of a breast bud to indicate term pregnancy. We're looking at the abdomen to determine if there is any trauma. We're looking at the umbilical cord to look at the number of vessels. We're looking at the size and the shape to determine if there's any distension, and there should be no distension. Abdomen should be symmetrical, round, dome-shaped, but not distended. We also want to auscultate the bowel sounds and assess for peristalsis, especially after they've breastfed, and you want to listen for about a minute per quadrant. Bowel sounds, again, should be present within an hour to 2 hours after birth, especially after they've breastfed. We should palpate the abdomen to determine if there's any distension, any masses. And the abdomen should feel soft, should feel non-tender. You shouldn't feel any masses. We're assessing the musculoskeletal system and assessing the range of motion of all 4 extremities, as well as their assessment, as well as the degree of their flexion and extension of extremities. And this will also give us some information about their neurological system. Normal findings will include full active symmetrical range of motion and flexion of all extremities, or most. We'll look at the hands, inspect the palmar creases, and we will also do the palmar grasp to assess their neurological system. When assessing the palmar grasp, you'll just take their hand, place your finger, and they should grasp. All 4 fingers and thumb should hold on. And we're also, before releasing the infant hands from the palmar grasp, allow the infant to lay its head and trunk back onto the flat surface and then abruptly let go. And then you'll also at that time can assist at the startle reflex, also called the Moro reflex. Normal findings include palmar grasp is positive, Moro reflex is positive, and there should be normal creasing within their hands. You're assessing a newborn's abdomen and Inspect and note abdominal distension. Prior to palpating, what should you do? If you said identify the time of their last feeding, you're correct. You want to assess the hips. The Barlow and Ortolani maneuvers should be done by a healthcare provider, but those are two maneuvers to assess if there's any hip dysplasia. It's important to understand what these tests are so that you can explain them to your patients. And this is just a kind of a skill of how to assess the hips. You want to gently abduct the hips while lifting forward. Feel for any clicks, crepitus, or clunks. And then you also want to observe the gluteal folds for symmetry by placing the patient in the infant rather in the prone position and looking at their bottom. And normal findings include no hip clicks or sounds of crepitus, and the gluteal folds should be equal. You want to assess their feet, look at their foot position, look at their toes, and observe any creases on the bottom of their foot. You also want to include the Babinski reflex, which is simply stroking the outer edge of the sole of the foot, moving from the heel up to the pinky toe, and observing the motion of the infant's toes by also conducting the plantar grasp. So remember, for Babinski reflex in the adult, the toes should curl in, but with an infant it's opposite. Up to 2 years of age, their toes will fan out. And the plantar reflex is very similar to the palmar reflex. Normal findings include 5 toes, positive plantar as well as a positive Babinski, and then there should be creases about 2/3 of the entire foot. When assessing the male genitalia, we're looking at their physical maturity as well as their testicular descent. We're also assessing the scrotum, the penis, as well as the urinary meatus on the penis. And with this, we'll place the index finger of the non-dominant hand over the infant's inguinal canal. Gently palpate the scrotum, gently using the index finger and thumb, and determine whether both testes have descended. And normal findings include scrotum has rugae, the urinary meatus is at the tip and not above or below, or not hypo or an epispadias, and both testicles are descended. With female, we will be looking at their labia, their labia majora, minora, their urethra, and any discharge. Usually the urethra is behind the hymen. The labia can be a little bit edematous. That's just the influence of the maternal estrogen. And there may be some clear or white mucousy discharge, which is normal. For both the male and female, we want to inspect their anus. If they're voiding, we want to determine the presence of urine, the coloration of urine, and they should, after breastfeeding, should have meconium within the first 24 hours. And then inspecting and palpating the spine, very similar to the adult. We'll be placing them in the prone position with their head, tilted to the side. Inspect the entire spine, palpate the entire spine, making sure that there is no deviation or scoliosis. The spine should be straight, midline, and there should be no bumps or dimpling. And we're assessing the neurological system, some of which we've already kind of done with the plantar, palmar, Babinski, Moro reflexes, gag, rooting, startle reflexes. We are assessing their state of alertness and their levels of reactivity. Normal findings for a cry is that it's strong, medium pitched, normal posture, muscle tone is symmetrical. When they're alert, are they alert? When they're quiet, are they quiet? When they're sleeping, are they sleeping? You're assessing an infant's feet. What are you observing for when you gently press the sole of their foot with their thumb near their toes? What is that called? If you said plantar, you're correct. And then infants don't really tell you if they're in pain. A lot of times you have to kind of identify the signs that they're exhibiting. So when we're assessing for pain, we're looking at their body for any skin color. Usually when they're in pain, their skin color isn't pink. They're very, very pink. They're crying. Their facial expressions are tight. They're frowning. When they're in pain, their muscle tone is rigid. Their activity level is aroused. They're hyper irritable, and they're hyper aroused. When they are not in pain, they're usually not crying. They're relaxed. They have normal tone, normal posture, and they're quiet. When assessing hydration, especially if they're breastfed, we do have to assess their fontanelles. And again, like I said before, if the fontanelles are sunken, usually it indicates that they're dehydrated. But another way to determine hydration is by looking at their stool and counting the number of wet and dirty diapers. And they should have at least one, 6 to 8 dirty 6 to 8 wet diapers a day, and at least 2 to 3 dirty diapers a day to determine adequate hydration. And infants should be fed at least every 1 to 3 hours, depending on how much they feed. And abnormal findings, infants feeding less than 6 times a day, or they're vomiting, they have less than 6 wet diapers in 24 hours, and then there might be uric acid crystals, which are just a red tinge to their urine. And then the final slide is Healthy People 2030. And an infant goal is to improve the health and safety of infants and reduce the incidence of sudden infant death syndrome, reinforce car seat safety and umbilical cord care, as well as reinforcing breastfeeding advantages and helping to identify postpartum depression sooner than later.